Welcome everyone to our sixth presentation in our series on clinical considerations of substance abuse and critical components of proper prescribing. We are pleased that you're with us again today in our last session to look at how to recognize symptoms of a substance abuse order. Dr. Whitsett is with us today to provide some very important information on this topic. As a reminder, each session is one Category 1 AMA PRA credit, and you will need to also complete the evaluation following this session in order to claim that credit. Because of technical issues that we've experienced today, I would encourage you to look for the email from KMA staff that will include a link to today's evaluations. In addition, we're so pleased to be partnering with the Kentucky Board of Medical Licensure to present these sessions, and we're also very grateful for the Federation of State Medical Boards Foundation and their support of these events. We acknowledge and are appreciative of their support for the unrestricted grant in the amount of $10,000 to support this activity. We hope that you found all of these sessions to be very informative and helpful to your practice. And with that, I'll turn it over to Dr. Whitsett to hear from him today. Dr. Whitsett?
Good morning, and let me pull up the share and we can get this going. And I just want to say hello to everyone. Certainly very appreciative of being invited by Miranda and Heather and their hard work this morning, particularly considering the outage. And hope in the next 45 minutes I can give you some information. I am an addictionologist. I'm an internist by trade. And surprising to some, we have a great passion for what we do. So before we get into the heavy hitter stuff, where we hope to talk about how to identify addiction, substance use disorders, and how to refer, I'd like to just bring up some light stuff. Oh yeah, my disclaimer, none, that's easy. And here's from the Weather Service, the smoke coming out of California from the horrible fires. And of course, the only benefit that I can see out of it for us is the fact that we are having beautiful sunsets. So you might take a look at the sunsets the last 5 days. This picture was taken, there's no editing here, from my cell phone on a walk Friday night. So tragic for the people in California, but yeah, excellent for those people that love photography. And for sports finally getting going, I think the football, National Football League starts a week from this Thursday. And of course, I'm a cyclist, so I'm excited because the Tour de France, any cyclists out there, this is day 2. So great to have things going again. The COVID has been deleterious, and I believe that Dr. Gupta mentioned how COVID has really devastated people that have and struggle with substance use disorders. My objectives today, I have 5 of them. How do you determine if someone has a SUD, a substance use disorder? How can you approach that patient if you think that they might have it and they're not interested in getting help? What are treatment options? And that includes just touching on medication-assisted treatment. Also, when are patients at risk for withdrawal? And then when do you refer a patient to get help or for treatment, and how do you do that? I'd like to just kind of cover the landscape of addiction. And this is what I do full time. And I will tell you that the addiction that's most prevalent in the United States is food. I don't treat food addiction, but 50% of Americans right now are overweight, 30 to 35% are obese. And so it is a real problem. I'm fascinated by this because I like to study the brain, and the brain involves cravings, which is kind of the center focus of all addictions, is the craving, the desire, and food is a beast. Well, which chemical addiction kills the most people? And I think you all probably familiar with this. Cigarettes and tobacco, which nicotine, of course, is the addictive substance. Nicotine itself is not particularly harmful, but it's all of the other components of tobacco that causes the deleterious effects that we see. And then, what's the most widely abused drug? Well, it's legal, it's sexy, and it has appeal, and it's alcohol. And I'm going to talk a little bit about alcohol today because I think it's becoming more a problem here in the last 10 years. I'm seeing younger and younger people coming for treatment that are actually suffering from liver failure in their 20s and early 30s. So alcohol is something very important to me as someone that treats substance use disorders. Well, the most widely used drug, that happens to be caffeine. Recent study shows that caffeine in coffee itself has actually some beneficial effects for those people suffering from liver disease. So there's many benefits to drinking coffee, but it is widely used, and it is being investigated as maybe the initial addiction that young people develop. That is, it might prime the brain, because the first chemical that's addictive that our children are exposed to is a caffeinated product when they drink soda in their youth. And which drug of abuse kills the most people? And again, we come back to alcohol. I know that we have talked about opioids. Dr. Gupta did a presentation talking about it. And yeah, we are in the midst of trying to resolve that opioid crisis. But alcohol is still killing more Americans than all other drugs combined. So it is a big focus for me in terms of trying to help people with addiction. This week, the government is suggesting that it might actually change the guidelines. Right now, the guideline is that men can safely drink 2 drinks a day, and women can only drink once a day. Seems a little biased, and they're starting to talk about maybe limiting men to only 1 alcoholic beverage a day. So that would be bad news for some of my neighbors. What's the most commonly used illegal drug in the United States? And that'd be marijuana. There's no doubt about it. And I don't know if it was talked on with the presentation yesterday, but yeah, Kentucky has the highest rate of illicit marijuana plants in the United States. Excellent to be able to hide it in the woods. And in the 90s, I've treated several of the farmers from Kentucky for alcoholism, and you know, they were all selling marijuana on the side because they said it was a cash cow for them. Canada's the second country to legalize marijuana. The first country, I doubt that you know this. This is a Jeopardy question. Uruguay, back in 2013, I actually had to look it up on a map because I couldn't remember from my 8th grade geographics where that was located. And we are in the midst of having problems with opioids and prescription pills that ramped up in the late 90s. A lot of discussion about how Purdue Pharma initiated that. I remember talking to my colleagues back then, you know, what's going on with all these pain doctors. Today, it's being looked at much more closely. The regulations have tightened, and I think that's been very helpful with regards to overprescribing of prescription medications. And of course, there's been an influx that we've talked about earlier this weekend about the heroin, fentanyl. It gets a lot of attention still. It's still a culprit in our community. Hepatitis C is epidemic. It's now the #1 leading cause in America for a liver transplant. Fortunately, we do have antibiotic treatment that can cure it. I've had patients that are cured in 8 weeks taking a pill a day. So it's a dramatic change, still pretty expensive, but hepatitis C remains a scourge, especially for those people that don't know that they even have it. HIV, AIDS is still a problem. We are seeing increased heterosexual transmission. There's a failure for young people frequently to take those precautions. And so it is still in the community. Well, what is addiction? It's a loaded question, I suppose. It's a brain disorder, a brain disease, if you will. We have good imaging data with dopamine transporter systems and dopamine D2 receptors, as well as functional MRIs that have delineated neural pathways that clearly show that the brain of someone that has a substance use disorder is different and responds differently to triggers than a normal person. It is characterized by compulsive behavior, continued use despite those serious negative adverse consequences, and also, again, those persistent changes in the brain. My patients go, well, why aren't you doing a brain scan on me to diagnose my disorder? And I said, well, I could, but there's no need to. It's expensive, and we already know what your problem is. But science has confirmed the fact that there are brain changes associated with it. Now, these are the 5 primary drugs of abuse that are treated most commonly right now. It doesn't mean that people don't present to me with LSD addiction or over-the-counter cough syrup addiction, dextromethorphan, or problems with loperamide addiction, Imodium. So these are the ones that we most frequently see. Still, alcohol is #1. Despite the opioid epidemic that's been going on, alcohol is what I treat the most, but we have marijuana as well as opioids that are still in the #2 and 3 slots. Methamphetamine in the last couple of years has made, at least in where I'm from, which is Claremont County, Ohio, has made a big comeback. The purity is high. And I think a lot of my patients that have struggled with overdoses from opioids, some of them have said, I don't want to die that way. And they've switched over to methamphetamine as their drug of choice. Addiction is used to describe compulsive drug seeking despite those negative consequences. And I don't use the terms addict and alcoholic in my medical terminology. They're not used in the DSM-5, and I'll kind of go over the DSM here in a second. The correct terminology that we use in our field is a substance use disorder. However, when I interview someone that presents to me, let's say for a drinking problem, after I interview them, I will frequently ask them, do you think you're an alcoholic? And they'll say, well, yeah, I think I am. And that tells me where they are with regards to understanding and accepting their problem. Because that's what this is about. Patients come to me because they have a problem. And hopefully in your practice, whether it's a private practice, a surgical practice, OB, emergency room, hopefully you'll be sensitive to being able to identify people that are struggling with problems with substances. DSM-5 is the current edition. It came out in 2013. There were a couple of changes that I'm not going to get into in great detail in my slides. I've delineated the criteria. It is based on behaviors. And that's important because a lot of people think, well, if you drink a certain amount, then you must be an alcoholic. And the DSM has outlined it so that it has more to do about the behaviors of the patient and the consequences that may be in, as a result of those behaviors. The one exception is cravings, and that's something that I haven't really appreciated until the last year or so, that when the American Psychiatric Association developed the DSM-5, they took the time to look at what really is the problem, and that is the brain disorder of cravings. And so they've included that as part of the criteria. I believe it's a medical illness. I know a lot of people are somewhat averse to the word disease, which frequently insinuates maybe a contagion, but I think it's a medical illness, a medical syndrome, if you will. And although the first drink or the first use of heroin or the first time people take a drug is voluntary, over time when they develop a pattern where they can't quit, that is addiction. And it does impact their health. It has great impact on the family. I always tell people this is a family disease. It's a family problem. Just like cancer impacts a family, so does having a substance use disorder. We grade the severity of a substance use disorder, so the DSM has changed in that way. It used to be like alcohol dependence and alcohol abuse. That's all gone. And today we talk about mild, moderate, or severe in terms of grading the intensity of the substance use disorder. Now recognize that having a SUD is really a great cause of disability and death and morbidity. We know that people don't readily seek treatment. I'm right now undergoing a family member who has struggled with his drinking for decades and is still not able to access treatment because he doesn't want to go. And we'll talk about that river in Egypt shortly. Yeah, they present with all kinds of problems. This makes the physician and the healthcare provider somewhat reluctant maybe to want to get involved. Legal problems, at-risk behaviors, problems with family members, spousal problems, children problems, parent problems, physical health issues such as cirrhosis, problems with infectious diseases from injecting drugs, mental health problems that coincide with it. So they do bring a whole palette of different issues to the table. These are some of the warning signs that you should be at least aware of, and family members may bring this to your attention. We'll talk about how the patient might bring it up or the family might bring it up, but these are some of the things that you might notice in patients when they present in your office or at the emergency room for issues. This is a list of the 11 criteria for the DSM-5. I'm not going to go into them today. I've provided them in the handouts. There is a typo in your handout, but it's corrected here. And it has to do with the craving that I mentioned earlier. I think that's a very subtle but important detail that the APA put in on the DSM criteria, because craving a drug, not even using it, but desiring to use it, is the problem. Even though people have problems and consequences, they continue to crave it. And again, this is one I've given as an example for an alcohol use disorder. And then here's one that I've handed you for an opioid use disorder. And note the caveat at the bottom. The opiate use disorder criteria is not to be utilized for patients that are prescribed opioids for chronic pain or otherwise. And so if they are taking it under appropriate medical care, these do not apply. Only for people that may misuse prescription opioids or using illicit opioids. And there's the grading that we use. And we take those 11 criteria. If you have 2 or 3 of the symptoms, it's mild. 4 or 5 of those symptoms, it's moderate, and more, 6 or more is considered a severe disorder. Well, how do you tell if they have a SUD? It's not always very easy, and sometimes it's in plain sight, and it's real easy. Screening is something that we are all supposed to be doing in our offices, in our private practices, in the emergency room, at the obstetrician's office. We are supposed to be doing screening. And I'm going to talk about SBIRT very quickly here. It's a major barrier because a lot of doctors and healthcare providers are not taking the time to do it. In part because it's hard to work with these patients. They're very time consuming. So part of the goal today is to help you formulate a plan to how to screen these patients in a timely fashion and then refer them out to someone that has the time like myself. So they can be difficult to work with. We recognize denial. It is a problem. You will face patients that have significant denial of having a problem. And we also know that people make up excuses. Many substance abusers, particularly alcohol, high functioning, have lots of excuses. And you have to at least be willing to listen to those excuses, document it, and then maybe down the road you're planting a seed for them getting help later. Some of the issues of making a diagnosis, not all patients agree with your diagnosis. You know, you might say, you know, gee, I think you're having problems with your drinking. I think you're having problems with your medication. I'm suspecting that maybe you're having misuse issues, you're overutilizing. So they can become argumentative and difficult to work with. It's not easy. Some patients will agree that they have a problem and they're like, I don't need your help. I got this. It's under control. Yeah, I've got a little bit of a drinking problem, doc, but you know what? I'm good and I don't need your help, but I appreciate you talking to me. I will tell you that most patients that I interview that come to treatment in my setting never disclose to their physicians or healthcare providers that they have a problem with a substance use. And I ask them, why aren't you talking to your doctor? And they say, I'm embarrassed. I don't want them to know. So it's difficult because I think it's important for us to all recognize that how you present yourself in terms of judging them means a lot to them. I've treated literally hundreds, if not thousands, of opioid addicts over the years, and they will tell me that they're very scared to talk to their doctor about their heroin use because they're afraid of being judged. So I think it's an important thing to hopefully break down. Yes, some will admit to a problem and they will want some type of help. And those are the patients that are maybe primed to get referred and to seek treatment and to get some assistance. So hitting rock bottom is no longer applicable. We try to help people at any stage of their illness. And our studies have shown that speaking to a patient that maybe has an early use disorder frequently will prevent them from going further in that progression because patients will listen to their doctors, especially with drinking, and take it to heart and make an attempt to cut back and control their drinking. One of the things that you have to be careful with talking about alcohol consumption is what is a drink. Now, these are the standards that are presented here that are the American standard for what a typical drink is. But when you're talking to a patient, their drink might be very different. So it's important to ask them, well, what are you talking about, a drink? And you know, sometimes you'll find out that a drink is a tumbler that's 32 ounces. So as you speak to people about their drinking, make sure to clarify what's the amount of a drink to you. Screening involves the SBIRT. And of course, SBIRT has been around since, I believe, the early 90s. And again, brief assessment. This cannot be a time sucker-upper, because if it is, you won't do it. But if you can put into place an SBIRT for alcohol and drugs, and a brief assessment, and a quick talking to those people that are interested in getting it, getting help for it, and being able to refer them out, especially if it's a dramatic crisis moment, the patients sometimes will present, particularly in the emergency room, which is where a lot of patients do present. And the evidence has been shown with the U.S. Preventive Services Task Force that this does work, particularly for tobacco and for alcohol problems. I suspect it works too for drug abuse. The studies are kind of waffling on that, but I think it can be very helpful, particularly for alcohol. How do you implement it? Well, obviously you have to talk to your staff about it. I recommend that the physicians have their ancillary staff do a lot of the work, the screening and the question taking. But it's a great opportunity when they come in for a physical or to get their medications refilled. Probably one of the most frequent things I see is patients that are coming in for a doctor visit for their medicines and their blood pressure is up. And actually their blood pressure is up because they quit drinking about 36 hours ago because they have a doctor's visit and now they have a little bit of rebound hypertension. So yeah, it's a great opportunity to talk to them and do some screening. These are the tests that I use, but I will tell you the ones that I like that are fast are the audit and the cage and the DAST. The assist is way too complicated. It's over my head in terms of time. And also, I think it's very important for younger people to have them do the cut-it screening for cannabis. But these are the tests that are frequently used to just screen for a substance use disorder. Again, if you like the assist, no harm, no foul, but I find it very hard to use. These other ones, they maybe take 12, 15 minutes. In our facility, we have them doing it on a computer so they can just fill it out real quick. The patient can do it. And these are self-help types of forms. Yeah, the SBIRT has been implemented in almost every type of medical care setting. So anyone that is involved in healthcare, other than a pathologist and maybe a radiologist, really we have an obligation to do the SBIRT and to check our patients. And recently not recent anymore, back in 2008, they said from the ACOG committee, look, it's time for us as obstetricians to be screening. And I will tell you that a lot of my women do not have primary care doctors. They see their obstetrician gynecologist. So again, it's endorsed, and all of our level 1 trauma centers have to have SBIRTs in place. Again, there's a continuum, of severity. We like to grade it. We generally find that most patients, over time, it will escalate. Not everybody, but for most people, if they're diagnosed with a substance use disorder at age 25, if they never seek treatment, you check back with them at age 45, it has generally worsened or progressed. Some have received treatment, but many have not. So trying to help identify it early and in a healthcare setting can be helpful in terms of mitigating the progression. So the 3 most common scenarios I came up with in a private practice setting are patients that are requesting help or they've continued to relapse despite having some prior interventions. And, again, I have patients that will come to me and they say, look, I've been going to my meetings and I've had some treatment. I've been an outpatient and I'm still drinking. What can I do? The other situation is when a family comes to you and goes, hey, my husband, he's drinking too much. What do I do with that? And then also, if you make a diagnosis or you feel that someone has a substance use disorder, what are you going to do with that information? How are you going to approach it in terms of being able to help that patient because they're maybe suffering from medical problems? The most important thing I can tell you that you should do, if this is at least of interest to you, is to be able to make a referral. I think having a referral is very important. I will hammer that in a subsequent slide. But you can also choose to handle this directly. And I encourage primary care physicians, family physicians, internists particularly, maybe learn a little bit about how to help these patients in your own practice. Much of it can be done, particularly with naltrexone and Vivitrol therapy, without an addictionologist referral. But the bottom line is you should have available a phone number and a place and a name of someone that you can send someone to. You have to have that available. It has to be readily available. You shouldn't have to spend 8 minutes having someone look it up. It should be something that you can quickly give to a patient. And when you refer a patient out for any type of treatment, it should have a name and a phone number attached to it so that they feel at least they have a place that they can call and talk to. The types of referrals that you can at least consider would be a therapist in your area, a drug counselor, having a clinical psychologist available that maybe has an interest in helping people with drug and alcohol problems, a psychiatrist, those people that are maybe being managed for a psychiatric problem as well, can benefit from having a psychiatrist for a substance use disorder, and to an addictionologist. And it depends on your location. Obviously, some places don't have an addictionologist available, but if you do have that name and number, make sure you check with them to find out if they're comfortable taking referrals. The types of programs that you have to be aware of include an OTP, an opioid treatment program, that is federally regulated, and they prescribed methadone as well as Suboxone products, generally, most of them anymore. You should also be aware of the substance abuse agencies in your area or clinics that will take patients, and also what types of patients will they take. And obviously, you need to know about the hospitals in your area that might be able to take someone that has a crisis for, let's say, an urgent detoxification need. Now, I want to just quickly talk about the 3 common drugs of abuse, and you may well know this already, but I want to make sure to remind you, that have the potential for life-threatening or harmful effects from acute withdrawal. That would be alcohol, benzos, and opioids. And I believe there was a presentation yesterday by Dr. Ryan about benzodiazepines. And I will tell you that in the addiction community, benzos are viewed kind of with a nefarious and evil viewpoint because we see so many complications in people with substance use disorder from benzos that are prescribed by doctors. However, I also have great respect for the fact that there are some patients that need benzodiazepines for well-being and good health. So I tend to see those patients that have a use disorder and it gets a bad rap. On the bottom, I talk about pregabalin and gabapentin because they can have a significant withdrawal presentation, and also antidepressants. You should be aware that they can have a discontinuation syndrome associated with abrupt withdrawal. Now, with alcohol, which is probably the most dangerous of all of the substances, those are the stages of withdrawal that we frequently reference: mild, moderate, and then the end stage, more severe DTs. When we start to see going up from the mild to the moderate and more severe, it has to do with autonomic reactivation. That is, you'll see people with elevated blood pressure, their heart rate goes up, they'll have sweating, diaphoresis, they might have an elevated temperature. And of course, when you get to the end stage of withdrawal, it has to do with the CNS. That is, alterations of their orientation and ability to be lucid. We use, to assess patients for a withdrawal syndrome from alcohol, what's known as the CIWA-AR. That's the revised CIWA, the Clinical Institute of Withdrawal Assessment for Alcohol. There's also one for benzodiazepines that I'm not really going to go over today, but you should be aware that for patients that present with benzo withdrawal, there is that assessment. It's fairly rapid, and it probably takes me 7, maybe 8 minutes to go through it with a patient. And if they score high, more than 8, then at least it gives me an idea of what the problem is. If they score usually over 16 to 20 in my office, I usually recommend that they seek treatment at a hospital or emergency room, because these are people that may end up with very severe problems with withdrawal that could be medically complex. Anyone over 20 certainly has to be, I would recommend referring to a hospital because they are at high risk for cardiovascular collapse and arrhythmia complications and seizures. There's also the American family practice. People have the SAWS, the short alcohol withdrawal scale. I like it, I don't use it, but it's also very quick, it's easy, and it gives you an idea in the past 24 hours whether or not they're having symptoms that are associated with severe alcohol withdrawal. Again, it's something to be aware of, that the SAWS is available and can be utilized. Probably one of the hardest moments is when you have a situation in your office where someone appears obviously sick. They're tremulous, they're shaking, and you get the history from the family. Well, he quit drinking about 36 hours ago because he's been drinking a case of beer and now he's trying to stop. And these are the people that you really have to consider getting in to the emergency room. Also, people that have acute toxicity that can't be managed easily in an outpatient setting. People that have underlying medical problems or heart issues, pulmonary problems, they need to be managed in a hospital setting. And if they present with acute psychiatric hallucinations and problems with suicidal, homicidal thoughts, obviously they have to be referred out. Now, talking about outpatient detox options for alcohol, and many of physicians, including my primary care physician, he manages his patients that have a mild alcohol withdrawal. So I want to talk about that quickly. If you choose to do that, it's actually a very fulfilling thing to do. The medication of choice, of course, is a benzodiazepine. I've used phenobarbital in the past. I don't use it presently. My drug of choice now is using Librium or chlordiazepoxide. I think it can be very helpful. Many physicians like to use Ativan because it doesn't involve hepatic metabolism issues. The problem with chlordiazepoxide is that you have active metabolites that can stick around and can accumulate if the liver is bad. So I tend to avoid Librium in people that have any evidence of hepatic failure. And there's nothing wrong with diazepam. It's well accepted, it's inexpensive, and is very effective. Well, when you refer this for the inpatient detox, if they have significant abnormal laboratory tests, elevated white count, they have problems with elevated bilirubin, concerns about their electrolytes, which is frequent with magnesium, as well as potassium. If they have a history of DTs or a history of seizures, these are people that are generally considered to be at higher risk. And if they have something going on simultaneously, like pneumonia or a urinary tract kidney infection, we usually recommend that they get referred out. Also, having a family support system. If you don't have family to help you, these are patients that are generally at high risk because they may not take their medication appropriately. They might get confused as they continue in the withdrawal. So I think it's very important to feel comfortable with the family that might be tending to them. If they also have serious psychiatric conditions or if their C was greater than 16, generally I don't recommend you try to manage these patients as an outpatient. Also, co-substances. Unfortunately, patients do lie to us. And I think it's important, try to get a point of care urine drug screen if you can on everybody. If you have that ability to see, is there cocaine in the urine? Is there maybe benzos in the urine? Is there possibly other substances that can be screened out? Because many people that drink heavily also use other substances. In general, I recommend, if you have it available, to talk to an addictionologist to have them review the case. You can always refer it out. If it's unavailable, the emergency room is that last ditch effort. I did emergency room work for a number of years. I'm not meaning to dump on the emergency room staff. They're wonderful. They do great jobs, difficult job. But when it gets tough, you refer them to the emergency room for an assessment and for stabilization if they need it. Now, to prevent relapse with alcohol, that is someone that's been struggling with their drinking, they don't really have a problem with detox, maybe they're binge drinking, or they have irregular use and they don't have physical tolerance, then these are the medications that you need to be aware of. Naltrexone is by far the one that's used the most. Some people are using Vivitrol, which is the injectable form. I use it a lot. It is by far the most prescribed of all the FDA-approved medications to help people that are struggling with an alcohol use disorder. I have used Antabuse or disulfiram in very select cases. I don't recommend that primary care doctors use it, although if you feel comfortable using it, go ahead. Just be aware that if you drink while taking disulfiram, it can be life-threatening because it interacts metabolically. And then Campril, a camprosate, has been FDA approved, and I think that there is a role for that, particularly with patients that have alcohol physical dependence issues, tolerance, and they come out of detox. A camprosate seems to be a medication that works well for them. But again, the go-to for me is naltrexone, few side effects, and of course naltrexone is used for opioid use disorder as well. So I'm going to skip over this because I'm going to come back to opioid use disorder, but I will tell you that these are the medications that are currently utilized by the FDA for MAT. I stuck this in here because I want you to be aware that those are the medications that are FDA approved for alcohol and for opioids. Those are the only two drugs where there's FDA approval for medications to prevent relapse. And again, I'm tickling this, but we'll talk more about that with opioids. Benzodiazepine detox referral. I rarely try to acutely detox people off benzos. These patients are generally managed with a slow outpatient taper. If patients insist on it, I recommend that it be medically managed in an inpatient setting. And also, if you're going to try to detox somebody from a short acting, switch over to a longer acting, like Klonopin or diazepam, to help them as they slowly taper. But a rapid taper is generally not advised, and it's rarely medically necessary. I want to go to opioids. The data that I'm going to present here have to do with overdoses. And about 70% of the overdose data that we see nationally involves an opioid. That is, at the postmortem with the toxicology, they'll see opioids present in about 70 to 75% of the cases. So it's not necessarily that this data reflects strictly fentanyl or heroin overdoses. Now, back in 2017, it was a record 72,000 overdose deaths. And again, a lot of the culprit, fentanyl, illicit fentanyl, as well as prescription pills. Then the next year, we saw a decrease, and we thought we were getting ahead of the curve because the overdose deaths went down, a decrease of about 4%. But then last year, it's back up. And so we are still struggling with this issue of overdosing. I think there's been an uptick from methamphetamine and cocaine overdoses, but many of those people will have mixed in that toxicology opioids as well as alcohol. So again, many of the fatal overdoses are unfortunately still from opioids. Your detox options for opioids, it's rare to have to admit someone to the hospital for opioid withdrawal. I only know of 2 cases locally in the Ohio area around Cincinnati where death has ensued as a result of detox without medical management. And they both occurred in a jail, one from an MI and the other from dehydration. So it's rarely life-threatening like benzos and alcohol can be. If someone is diagnosed with an OUD, the outpatient setting is generally recommended. And if you have OBOT, which is office-based opioid treatment waiver, to utilize buprenorphine or Suboxone, it's a magic. It really works very well. But also you have methadone, which has to be done at a methadone clinic or an OTP. But buprenorphine is a magic medication for helping people withdraw off of opioids. So again, those are the 2 big options. And if you don't have a waiver, then you're going to be looking at comfort meds. And these are the comfort meds that we recommend. Clonidine has been used for 30, 40 years to help people come off of opioids. I don't use it a lot. I still do use it. Zofran is helpful in terms of the nausea that might ensue with opioid withdrawal. I always prescribe in patients that I trust, and I'm not using buprenorphine products. If they're going to have a withdrawal from an opioid and they're going to manage it at home and they have a family member with them, I always prescribe benzos to them to help get them through this because it lasts 5 to 7 days, can be very uncomfortable. And I also use gabapentin to assist in the withdrawal, which can be very helpful. So those are the alternative comfort meds that are utilized for outpatient opioid detox. There is also the URAD, or ultra rapid opioid detox. I don't believe in it. I don't recommend it. It's still being advertised. It's on the internet. You can fly to New York, San Francisco, wherever, and get this done. It can be dangerous. The studies show that there are occasionally life-threatening manifestations. So I do not recommend rapid opioid detox. And then now there are studies showing that even people that have this will have lingering pause symptoms for weeks on end that are not addressed with the rapid detox. More importantly is the maintenance treatment options for someone that has an opioid use disorder. And there is no doubt that the two medication groups are naltrexone, which is an antagonist, and that also comes as an injectable form, which is monthly in the form of Vivitrol. We use a lot of naltrexone for opioid use disorder, a lot of Vivitrol. Vivitrol seems to be more effective because of compliance issues with the naltrexone. And there's no doubt that this is an important medication in treating people that have maintenance problems staying off opioids. It can be very effective. There's also agonist therapy with buprenorphine or Suboxone products. And then there's what I call king of the hill, which is methadone, which should be really, for most patients, the last choice. But studies have shown that for people that have serious opioid use disorder, severe, the best medication of choice is definitely methadone. It has a better success rate than even buprenorphine or Suboxone. So if I have patients that have repeatedly failed Suboxone treatment, I ultimately make a referral to a methadone clinic to help them get sober, stay off their heroin. You should be aware that this is the U.S. Surgeon General's advisory on naloxone. It's very important that any patient that is being prescribed an opioid, any patient that you have knowledge of that is misusing an illicit opioid, these patients should all be prescribed naloxone in case of an overdose. I frequently will prescribe it to family members if their loved one is struggling with addiction. So this is important. You can get this over the counter here in Ohio at some of our pharmacies without a prescription from a physician, but I think that everyone should be prescribing naloxone to those patients that are being prescribed. And here in Ohio, we have the ORS monitoring program. I believe that you've gone over the CASPR this weekend. I'm assuming with CASPR, as in Ohio, we have mandated reporting of any prescription with naltrexone or naloxone. It should be on that CASPR report. Regarding maintenance medication-assisted treatment, there's been a lot of pushback about, oh, you know, you're going to get addicted to Suboxone. You're not sober if you're on Suboxone. It's a bad way to go. Oh, you're on methadone. And they recently, just past week out of JAMA, they went ahead and looked at residential programs, which is what I'm involved in. And they said only about a third of them are recommending some type of medication for an opioid use disorder. And that's really a travesty. We need to be recommending, now certainly a patient has a right to refuse, but we always recommend at our facility, all opioid abusers, the opportunity to either be on an antagonist medication like naltrexone or Vivitrol, or on Suboxone. I rarely refer to methadone in a residential setting because we can't provide them that type of service, but they should be offered something. And to think that only a third are actively prescribing MAT for opioid use disorder, because these patients, especially injectors and using illicit street fentanyl products, are at very high risk for an overdose. The standard of care for treating an opioid use disorder is using some type of medication. The problem with antagonist treatment, naltrexone and Vivitrol, is it's hard to get someone using street heroin or fentanyl off of the medication long enough so that you can start the antagonist therapy. They have to be clean for at least 7 days, because otherwise you'll put them into withdrawal with the antagonist therapy. Well, I'm going to briefly go over these case reports. I'm not sure exactly how much time I have left, but I will tell you that the first case is someone that came to our clinic that indicates a problem with drinking, elevated blood pressure, some abnormal liver function tests on a routine. They have a 0 on their breathalyzer. Their drug screen is negative. Their C was low, obviously an overutilizer of alcohol. And so I remind you that addiction is about the consequences from drinking, and he is considered to be a high-risk drinker. That doesn't necessarily mean he has a substance use disorder. So with alcohol, we have to be careful as far as labeling someone. Again, if you're having more than 4 drinks on any day, or 3 for a woman, then you're considered to be a high-risk drinker because that's heavy alcohol use. I like to ask my patients, what problems have you had as a result of your drinking? And try to dig in a little bit. These are some of the sample questions that you might want to ask. Again, it's important to have ancillary staff ask these questions. or if you have the time to do this. I have the time as an addictionologist. I'm able to sit down and ask these detailed questions. This will take time to do. So sometimes it's best to have an ancillary staff member do it, because many people in an emergency room or in a private care setting don't have the ability to look at this information. But these are the questions that I typically will ask. Here's the audit. You can have someone interview them. Again, I like the self-questionnaire. This is the self-report version. Have it on your computer. Have the patient sit down on the computer and fill it out. That's what we have them do at our facility. So again, the self-report version, very easy to use, and they can answer it, and it gives you an idea of where they're at. Score of 8 or more, it's hazardous or harmful alcohol use. So it's a good screening measure to determine if someone has a problem. And then I always try to tell them, when I talk to someone about their drinking problem, approach it from, do you have an interest in cutting back? And many do. Many are aware that they're drinking too much. So I try to bring it up in a very benign way, as well as not being threatening. If the person becomes resistant, and if they have fear and stigma about the way you are approaching your questioning, they will shut down. And so it's very important to be non-judgmental with how you talk to them about their drinking patterns. That's the number one thing I hear from patients is, my doctor has judged me because of the way I drank. Please take the time to be kind and compassionate. Displaying compassion is probably the one thing that you can change if you are not being that way, to help people so that when you approach them about a drinking or a drug problem, you can at least have them talk to you openly. Make sure to talk about your concerns if you're seeing elevated LFTs, or if you see some problems in terms of electrolyte issues. Provide reassurance to them that it's very treatable if they've acknowledged that they might have a problem. And then ask them, well, how do you feel about my concern for you? What do you think about that? Case number 2 is someone that has type 2 diabetes, not well controlled, has history of coronary disease, elevated blood pressure. Their C was elevated at 18. She doesn't feel very good. I recommend that these patients get referred to a facility or to an addictionologist for management, because these are higher risk patients. These are people that may well have a problem or complication coming off of the alcohol. The concern for addiction with opioids is shared by everybody today. I mean, the families are worried about it. You're prescribing opioids to someone. Patients are worried about it frequently. And doctors are worried about this overprescribing of opioids. Behaviors are obvious to most of us. When we start seeing them using a family member's analgesics, when they're escalating their dose, when we see them run out of medications early, they're getting doctors and doing doctor shopping, which has really been shut down, I think, a lot by Casper and by ORS here in Ohio. So these are the behaviors that are red flags to all of us. Selling prescription drugs, this was my first experience with addiction when I was a resident here in Cincinnati, and I prescribed a young woman who had terrible teeth, and she was complaining of a bad toothache, and I prescribed her some hydrocodone for the pain, and I ended my shift at 8 a.m. and walked out in the parking lot, and I literally saw her selling the prescription that I had just given her. And I came up and go, "Are you selling those?" She goes, "Yeah, sorry." And that's what she said to me. So yeah, forging prescriptions, selling their medications, using intranasal use. Obviously, it's not a normal route of ingestion. They continue to lose their medications. I think it's required now that they have to fill out a police form. But when I talk to the police, they say they know that the patient's lying because they've had it multiple times. You have to be very careful with that. And theft of paraphernalia from hospitals is obviously a clue. This is the form that you can use for the diagnosis of an opioid use disorder. It actually looks pretty presentable when it's in a form. Get a form like this into your practice. You'll find out that it's very easy to use to help you go through whether or not someone might have an opioid use disorder. And if you're having a withdrawal assessment, when you use a COWS, which is the Clinical Opioid Withdrawal Scale, this is the scores that these are the scores that we typically grade them at. And when people get to 13 to 20, they're having fairly moderate symptoms and they're going to be uncomfortable if it progresses. So be aware that a COWS is what we use at our facility, and addiction facilities use a COWS for an opioid withdrawal assessment. CWA for alcohol, COWS for opioids. And here's the form that I use for a withdrawal scale. It takes about 7 minutes to do. The thing I don't like about it is some of the questions have to do with subjective reporting. But again, you can obviously see the resting pulse rate is up. You see them yawning. You also see that they have a tremor. They have piloerection. They have diaphoresis. And they also might have a runny nose, which is almost always one of the initial presentations is runny nose and yawning. And my last case that I want to go over is a case that I took care of maybe about 10 years ago. Had osteo when he was younger, had been prescribed about 50 MME daily, morphine equivalents. And, you know, he had it abruptly stop because he tested positive by his pain doctor with THC, came into me and he was in withdrawal. Vital signs were stable, but he had an elevated COWS, had sniffles, no IV tracks. He'd been eating them, not snorting them, and was in moderate withdrawal. So, you know, the options that I had, because I had a waiver, I started him on a buprenorphine product with Suboxone. You can refer to a detox specialist if you're not comfortable with patients like this. You can go to the emergency room. You can also refer them to a methadone clinic if that's available, because they might be able to provide very prompt treatment for someone that's in acute withdrawal. And you can always provide them comfort medications like I described, which is a benzodiazepine along with Klonopin, Zofran. You can use Imodium, and then there's gabapentin. But make sure that the family has naloxone, and you should prescribe the patient and or a family member naloxone at that time so that they have it available in case they have an opioid overdose at home. So my summary recommendations, I recommend these tests to have available in your office for quick screening, audit, and a cage. The cage is very simple, it's 4 questions. I also recommend using a CWA and a COWS for withdrawal assessments if you're having patients that might have withdrawal in a primary care setting. And the Academy recommends using the SAWS, or the short alcohol withdrawal scale. We also will see people that continue to relapse despite having treatment. That's very frustrating. It's frustrating to me. We see it a lot. It's important to provide medications, especially to relapsers, people that have gone back to use. I'm very big on prescribing naltrexone, particularly for alcohol. And when they're asking for help at a higher level of care, you know, make sure you have referrals available so that you can refer them out so that they don't just get a recording, which is horrible. Hopefully a person will answer that phone so that they can talk to someone at a crisis moment. Your non-judgmental approach is very important in how you handle and talk to patients that have a use disorder. Find it in your heart to be able to slow down and take the time to be empathic with these people. They are suffering. And even though their behavior can be reprehensible, they are really suffering with this horrible illness. And many will respond to empathy. Using Suboxone if you're wavered, use of benzos for alcohol withdrawal. These are all the tips that I recommend. Tapering your opioids is important for those patients that might have a pain disorder. And I don't want to get into the chronic pain issue because that's not my area. And making sure that you use comfort meds for those patients. You can make a difference in your practice for these patients. And that's all I have for today. So I appreciate everyone taking the time. It looks like a beautiful day, at least here in Cincinnati. And I gave this lecture to my daughter the other day and she fell asleep. I hope I didn't do that to you. If you have questions that you want to reach out to me, I'll be glad to respond to emails and answer those. And if you have questions right now, I'm glad to answer those as well. Thank you for your time and have a great weekend.
Thank you so much, Dr. Whitsett. We actually do have a few questions if you have a moment. One of our physicians asked if you could comment on your thoughts on the needle exchange program.
Yeah, I'm a big believer in the needle exchange program. I think that we have it here in Ohio. We have several outlets where people can do that. Some of my colleagues believe that what we're doing is we're giving the okay to using a needle. I will tell you that my patients, when they are in the midst of using injectable drugs, they just will not they'll ignore any health and safety concern and will reuse a needle that they can find on the street. That's how desperate they get. And they know retrospectively it's bad. Having safe needle available to inject helps reduce the infectious diseases that we're seeing with valve transplants, septic emboli, problems with transmission of hepatitis and HIV. So I am an advocate for the exchange program. And I don't believe that because someone that decides to go that path, they're going to use a needle. And I don't think making it available promotes people to be addicted.
Thank you so much. So our next question is asking about some resources or books that you would recommend for physicians interested in exploring substance abuse and treatment further.
Say that question again. I don't think I understand it. Try it again.
So the physicians are looking for some resources, possibly books, video formats that would explore substance abuse at a deeper level.
Well, of course, I'm a big believer in the ASAM publication, which is it's called Addiction, and it's a great resource. It's a large textbook. I use that. It's kind of my Bible. But ASAM, the American Society of Addiction Medicine, has wonderful resources online. And I highly recommend that you go to the ASAM website and look around. They have books, video lectures, educational CME formats, and wide availability of different types of educational videos and reading materials. So if you go to the ASAM website, you'll find a trove of good resources for that type of information. But again, I use the ASAM addiction textbook. It's like 800 pages and it's kind of my Bible.
Perfect. Okay, shifting gears a little bit, we have a few questions regarding cannabis. One physician asks, is marijuana addictive? Does it have a withdrawal symptom?
Well, first of all, I read just this morning that the House of Representatives in Congress next month is likely going to propose that they decriminalize marijuana federally. As you know, it's a Schedule I drug by the DEA. So it'll be interesting to see how this plays out. First of all, yes, cannabis is addictive. I have patients that develop a cannabis use disorder, and that becomes problematic for them. I've had airline pilots in my program that have smoked marijuana and have a cannabis use disorder. Even physicians get referred to me for cannabis problems. So yes, a use disorder does occur. My first experience with a withdrawal syndrome with cannabis was in 1995 when a patient came from Jamaica to the airport. Apparently, about a day or two later, became very sick, presented to our emergency room, and I admitted him, and he was smoking 5 to 6 blunts a day. And a blunt in Jamaica in 1995 was using corn cob to roll their marijuana. So he was probably smoking 30 to 40 joints a day. His withdrawal syndrome included nausea, vomiting, agitation, insomnia, restless legs, and anxiety. And I treated him with benzodiazepines and medications for his nausea, vomiting, and an IV. And over a period of 36 hours, he improved. You don't see it that often, though. It has to be very heavy use. Now, recognize that today's marijuana, particularly with dabs, the highly concentrated THC, people can use large amounts because the marijuana that they're selling in Colorado is not my daddy's marijuana. It's strong stuff. So yes, you can see a withdrawal syndrome, and yes, you can develop a use disorder.
Thank you for that. As a follow-up, I'm pulling up another question regarding cannabis. This doctor says, I'm so confused about the abusive potential of cannabis. Is it equal to alcohol and opiates?
Surprisingly, what I have found is that there are a large number of people that do not like cannabis. So I'll see heroin addicts and alcoholics and people with methamphetamine addiction but they don't like marijuana. So it's very dysphoric to about 30% of people that I've interviewed over the years. It just makes them feel weird and dysphoric. On the other hand, I will tell you that they've looked at marijuana for medical purposes to help people mitigate opioids. And the medical board here in Ohio has determined that there's insufficient evidence to recommend that medical marijuana have listed as an opioid use disorder. So is it a problem? We have seen an increase in the number of emergency room visits in Colorado because of the legalization of recreational marijuana. We've also seen younger people using marijuana at a younger age because of the availability. As far as it being terribly harmful, I will tell you that over 100,000 people are going to die from alcohol-related problems in the next year in America. And I cannot think of anyone, maybe 2 people, that have died from marijuana use. But there is grave concern about the psychological impact of marijuana use long-term as well as at a young age, with increased anxiety, increased rates of schizophrenia potentially. So there are some harmful effects to marijuana, but death does not occur very often with marijuana.
Thank you for answering that. One last question on marijuana, and then we will close our session today. This individual is asking about commercialization or legalization of the plant or product. The THC content became tweaked to a higher level. Does the DEA have a limit for THC content for the marijuana sold commercially in the USA?
I do not know of any. Of course, I am not a DEA agent. I don't have the specific answer, but I'm not aware of it being regulated by content. Back in the 60s, when they were doing THC evaluation of street marijuana, it was anywhere from 0.7 to maybe 1% in terms of THC content. The latest I found in Colorado was a brand called Godfather. And I think they measured 36 to 37% THC. Speaking to patients that have been to Colorado and used this stuff, they will tell you that 1 or 2 puffs on this stuff and they're high. So it is very potent. I personally think that they should consider limits on it, but I am not aware of any limits on it. One of the big concerns that I have is there's another, you've heard of CBD, cannabidiol, which is the second ingredient in marijuana. And there is a ratio naturally that occurs between THC and CBD. And unfortunately, what these breeders have done, they've raised the THC levels so high, and the benefits of CBD, and you've heard of CBD oil, it's sold over the counter, and that has a calming effect and can help. I think the ratio is so high that there are concerns about psychiatric issues with regards to it. So yeah, I'm not aware of any specific cutoff level for THC.
Thank you so much, Dr. Whitsett. I don't know that you've had an opportunity to look at the chat, but I just wanted to say how thankful we are for all of the information you've given us today. The feedback has been extremely favorable. They've really appreciated the amount of information, the detail that you've given it. Several physicians have commented about the compassion that you've added to exploring this topic and how that can relate to patients. So we are all grateful on behalf of the Kentucky Medical Association to have you with us today, and we thank you for such an informative presentation. And I thank all of you that have joined us today and yesterday for being a part of this series. I hope you have a wonderful weekend, and we look forward to seeing you all virtually soon. Thank you again, Dr. Whitsett.
Thanks, Miranda. Bye-bye.